Morning all. Today we shall discuss about gingival diseases in children. Gingival diseases in children can be broadly classified into plaque-induced gingivitis and non-plaque-induced gingivitis. Plaque-induced gingivitis can be chronic gingivitis, eruption gingivitis, gingivitis modified by systemic factors, gingival diseases associated with nutritional deficiency and modified by medications. Gingival diseases modified by systemic factors include puberty gingivitis, diabetes mellitus associated gingivitis, and leukemia associated gingivitis. Gingival diseases associated with nutritional deficiency include ascorbic acid deficiency gingivitis. Now moving on to non-plaque induced gingivitis, it includes gingival diseases of viral origin, fungal origin, bacterial origin, genetic origin, gingival manifestations of systemic conditions like mucocutaneous lesions and allergic reactions, traumatic gingival lesions, and foreign body reactions. Now let's first discuss about plaque-induced gingivitis. First one is the chronic gingivitis or the marginal gingivitis that we usually encounter in our clinical practice. What is gingivitis? As the name suggests, it is the inflammation of gingiva. Inflammation of the gingiva that surrounds the tooth without any detectable bond loss or clinical attachment loss. The major etiological factor that is associated with the prevalence of gingivitis or the significant periodontal disease is calcified or uncalcified bacterial plaque. Epidemiological studies have found that the prevalence of gingivitis in children is as high as 99%, especially in children with special healthcare needs. And the gingivitis of primary dentition is usually limited to marginal gingiva. However, the etiology of the same is unknown. Even though gingivitis is seen in children and adolescents, severe gingivitis is uncommon. Most of them will be having a mild and reversible gingivitis. Now coming to the clinical findings of gingivitis. As we said earlier, gingivitis is the inflammation of the gingiva. The gingiva will be showing redness and swelling, that mainly the marginal gingiva, and there will be bleeding upon rubbing. If the gingivitis or the persists, the tissues that were initially soft and edematous can become more fibrotic. Okay. The gingivitis, it is found that gingivitis does not always progress to periodontitis, but periodontitis is always preceded by gingivitis. Now coming to the management of gingivitis or chronic gingivitis. Early gingivitis, as we mentioned earlier, is quickly reversible. It can be treated by good oral prophylactic treatment and maintenance of good oral hygiene by proper tooth brushing techniques and flossing techniques. Gingivitis is generally less severe in children than in adults with similar plaque levels. Now let's see why the prevalence of gingivitis is less in case of children. There are three major reasons. First one is regarding their metabolic activity. In children, they'll be having greater metabolic activity and their anabolism is dominant over catabolism. So that the periodontium offers greater resistance to breakdown. And whenever that breakdown occurs or whenever that bacterial invasion occurs, there are chances for the periodontium to repair and regenerate. The second reason for the lesser prevalence of gingivitis is the difference in oral flora. The oral flora present in the bacterial plaque is established later, that is the anaerobic bacteria. Anaerobic bacteria like spirochetes, bacteroids, and melanogenicus, which is associated with gingivitis in children, is found to be have less later established, so that there will be delay in the onset of periodontal disease in children. Another factor that contribute to the lesser prevalence of gingivitis in children is the composition and metabolism of the plaque. Studies have found that the bacterial plaque found in children is of lesser irritation potential. Another reasons or the other reasons that accounts for the lesser prevalence of gingival diseases in children include decreased leukocytic migratory rate, lower tissue response, and lesser gingival permeability to bacterial antigen. Now let's discuss about eruption gingivitis. Eruption gingivitis is a transient type of gingivitis that occurs in young children when their primary teeth or permanent teeth are erupted. And the greatest incidence of eruption gingivitis is seen in the age group of 6 to 7 years. That is when the permanent teeth begin to erupt into the oral cavity. It occurs because the gingival margin receives no protection from the coronal contour of the tooth, because the tooth is in the stage of active eruption and it is not out of the, it is not in complete eruption stage, not in occlusion, so that the gingival margin doesn't receive any protection from the tooth, so that it is more prone to bacterial invasion and inflammatory process. And also, the food debris, material alba, and bacterial plaque often collect beneath these gingival tissue that covers the partially erupted tooth and thus initiates the inflammatory process, thereby leading to gingivitis. Now coming to the treatment of eruption gingivitis, usually the eruption gingivitis is self-limiting and thus the mild eruption gingivitis does not require any treatment. If the eruption gingivitis progress to pericoronitis, irrigation with counter irritant should be done. And if the pericoronitis is associated with side swelling and lymph node involvement, antibiotic therapy has to be initiated. Herpetic gingivostomatitis. You all know that the herpes virus is a virus that causes viral infections, and the herpetic gingivostomatitis is the infection of the gingiva caused by herpes simplex virus 1 infection. Usually, the primary infection with herpes simplex virus occurs in children younger than 6 years of age, and it is believed that 99% of all the primary infections are of subclinical type. And in some preschool children, this primary infection can be characterized by 1 or 2 mild sores in the oral mucous membranes. And in other children, these primary infection can be manifested with acute symptoms, and it is known as acute herpetic gingivostomatitis. Now coming to the general clinical features, usually this herpes simplex virus infection has a sudden onset of, that is symptoms develop suddenly. The patient will be having fiery red marginal gingival tissues, and the infants may show irritability and refusal to take food. This viral infection is usually associated with prodromal symptoms like headache, fever, and malaise. Usually, there will be cervical lymphadenopathy, and the fever will be as high as 101 to 105-degree Fahrenheit. There will be herpetic vesicles formed around which may rupture and form ulcers, and this may lead to pain while food intake and also during intake of any liquids of acidic content. Now coming to the oral findings, there will be yellow or white liquid filled vesicles. In a few days, these vesicles rupture and form ulcers of 1 to 3 mm in diameter. And these ulcers are covered by whitish gray membrane and have a circumscribed area of inflammation. And these kind of ulcers are usually seen on buccal mucosa, tongue and lips, hard and soft palate, tonsillar areas, gingival tissues, and mucobuccal fold. Coming to the treatment. This viral infection usually runs a course of 10 to 14 days, and the treatment include antiviral medication and provision of relief of the acute symptoms or the supportive care. The antiviral medication that is usually prescribed is acyclovir. If the disease is diagnosed or the infection is diagnosed within the 3 days, acyclovir can be given at a dosage of 15 milligram per kg 5 times daily for 7 days. If the disease or the infection is lately diagnosed, it is found that acyclovir is of limited value. These systemic antiviral medications can be combined with systemic analgesics for the pain relief. For immunocompetent patients, we can also add antibiotics. Along with this antivirals and antibiotics, mild topical anesthetics can be given for pain relief along with vitamin supplements. Apart from these medications, patients should be advised to take bed rest, take soft diet, and the patient should be well hydrated with proper liquid intake. Since this infection is contagious, it is also important to isolate these children or these patients with herpes simplex virus infection from other children to prevent spread of disease. Recurrent herpes labialis. We already discussed about the primary lesion, the primary herpes simplex virus infection. After this primary initial attack, this simplex virus becomes inactive and they resides in the secondary ganglia. This virus often reappears later. Usually, they get activated later as a familiar cold sore or fever blister on the outside of the lips. Thus, this disease is referred to as recurrent herpes labialis. And the recurrence of this disease is usually associated with the development of emotional stress and lower tissue resistance resulting from various types of trauma. And 5% of this recurrence is intraoral. And sunlight exposure may be responsible for the appearance of herpetic lesions of lips. ANAC or acute necrotizing ulcerative gingivitis. It is also known as Vincent infection. It is rare in preschool children and usually occurs in children from 6 to 12 years old and is more commonly seen in young adults. Here, the most characteristic feature with the ANAG is the involvement of the interproximal papillae and the presence of a pseudomembranous necrotic covering of the marginal tissue. The microorganisms involved in ANAG are Provatella intermedia, Fusobacterium, Treponema, and Salmonella species. Clinical manifestations of ANAG. As we said earlier, the lesion starts to appear in the interdental papillae and there will be inflammation and painful bleeding gingival tissue. There will be characteristic punched out appearance due to the ulceration and necrotic papillae and the gingival margins. Patient will be having poor appetite and will be having fever as high as 40 degrees Celsius and also is associated with general malaise, radiating and gnawing pain that increases with the intake of liquids or food. The Patient also often complains with fetid odor and foul metallic taste. And this ulcers seen the oral cavity are usually covered by yellowish, white, or grayish slough termed as pseudomembrane. And the removal of this pseudomembrane results in bleeding. The another finding found in these patients are the formation of deep pocket with gingival necrosis. Now we can see the staging or the clinical course of ANAC. There are 7 stages for acute necrotizing ulcerative gingivitis. Stage 1 is necrosis of the tip of the interdental papillae. Stage 2, necrosis of the entire papilla. Stage 3, necrosis extending to the gingival margin. Stage 4, necrosis extending to the buccal or labial mucosa. Stage 5, necrosis extending into the buccal or labial mucosa with necrotizing stomatitis. Stage 6, necrosis exposing alveolar bone and necrotic stomatitis. And stage 7, necrosis perforating skin or cheek, which is known as norma. Coming to the treatment, the goal of the treatment is to reduce the microbial load and to remove the necrotic debris so that the repair and regeneration of the gingival tissues can take place. First of all, under LA, this necrotic tissue is gently removed with a cotton swab, and thorough ultrasound scaling is done to remove the bacterial plaque and calculus. After which some gingival curettage and defragment is done, then antibiotic therapy is advised. Antibiotics that is given is amoxicillin 500 mg every 6 hours for 10 days. For patients with patients who are allergic to amoxicillin, erythromycin 500 mg or metronidazole can be given. Along with the antibiotics, mild oxidizing solutions like hydrogen peroxide diluted with water can be used after each meal. It can be substituted with twice daily rinsing with chlorhexidine mouthwash. Along with the mouth rinses and antibiotics, analgesics can be prescribed for pain relief. Patient is advised to take a to take rest and vitamin supplements are given. After all which, comprehensive plaque, after the acute symptoms subsides, comprehensive plaque control regimen and periodontal therapy should be initiated. Puberty gingivitis. As the name suggests, this gingivitis is this type of gingivitis is the gingival inflammation that is seen during puberty without the increased level of plaque accumulation. Studies have found that along with the hormonal changes, Provatilla intermedia is also associated with the occurrence of puberty gingivitis. Clinical features of puberty gingivitis: it is characterized by pronounced inflammation and bluish discoloration of the gingiva. And this kind of gingival enlargement is marginal in distribution. And if there is any presence of any local irritants, it will be characterized by bulbous interproximal papillae. This type of gingivitis is usually confined to the anterior segment and may be present only in the one arch. Usually, the lingual gingival tissue remains unaffected. Treatment of mainstay of treatment of the puberty gingivitis is the maintenance of oral hygiene and the removal of local irritants, restoration of caries tooth, and adequate nutrition. In severe cases of hypoplastic gingivitis that does not respond to the local or systemic therapy, gingivoplasty can be done. Ascorbic acid deficiency gingivitis. It is also known as scorbutic gingivitis and is seen associated with vitamin C deficiency. In this kind of gingivitis, gingiva appears bright red, swollen, ulcerated, and it is susceptible, easy to bleed or susceptible to hemorrhage. It is also usually limited to marginal tissues and papillae. Child may often complain with severe pain. Management Management is complete oral care and improved oral hygiene. Proper brushing and proper flossing should be advised. And for vitamin deficiency, vitamin supplements can be given. The gingivitis responds dramatically to daily administration of 250 to 500 mg of ascorbic acid. Older children and adults may require 1 gram of vitamin C for 2 weeks for the for the early recovery. Finally, drug-induced gingival enlargement. Drug-induced gingival enlargement, there are certain cases with certain drugs, the gingiva shows enlargement, and the most frequently implicated drugs are phenytoin, cyclosporin, and nifedipine. Phenytoin, it is an anticonvulsant used in the management of epilepsy, and this kind of enlargement occurs in 50% of patients who are taking this drug and is most severe in teenagers. Cyclosporin is an immunosuppressant drug that is used widely in organ transplant patients, and this kind of gingival enlargement is seen in 30% of patients taking the drug, with the children being more susceptible than adults. Nifedipine is a calcium channel blocker that used in patients with cardiovascular problems. The incidence of gingival enlargement with nifedipine is 10 to 15%. The clinical changes with drug-induced enlargement are very similar, irrespective of the drugs involved. The first signs of changes are seen after 3 to 4 months of drug administration. First, the interdental papillae become nodular before enlarging more diffusely to encroach upon the labial tissues. The anterior part of the mouth is severely affected and frequently involved, so that the patient's appearance is compromised. The tissues can become so abundant that the oral functioning like eating, speaking, and other functions are impaired, along with the aesthetics. This enlarged gingiva is pink, firm, and stippled in some patients with good oral hygiene. But if there is any pre-existing gingivitis, this gingiva exhibit classical signs of gingivitis. Management of gingival enlargement. A strict program of oral hygiene instructions, scaling, and polishing must be implemented. And in severe cases of gingival enlargement, needs surgical excision or gingivectomy or gingivoplasty can be done to produce an architecture that allows adequate cleaning for the easy access for cleaning. A follow-up program is essential to ensure high standard of plaque control and to detect any recurrence of enlargement. When the phenytoin induced enlargement is refractory, the patient's physician may be requested to modify or change the anticonvulsant therapy to drugs such as sodium valproate or carbamazepine that does not cause gingival problems. This phenytoin can be substituted with sodium valproate or carbamazepine, whereas for cyclosporin there is no alternative. However, the patient inevitably require indefinite oral care in such cases. So to conclude, periodontal disease in adults has its etiology as gingivitis in their childhood. So early detection, prevention, and treatment of gingivitis in young children is vital for the reduction of the periodontal diseases in adults. Thank you.